This conference will now be recorded.
Okay, hi, welcome everyone. We're here tonight again. My name is Caitlin Esposito. I always forget to do this, from the Bobby Jones Chiari and Syringomyelia Foundation. Tonight we have with us our C-Board Chair, Dr. Cormac Maher. He is a pediatric neurosurgeon at the University of Michigan, and he has done a lot of work really kind of understanding the natural history and to the best of our ability, and the underpinnings of a lot of stuff related to Chiari malformation and Syringomyelia, and scoliosis actually. So I'm wondering if we could talk about that a bit. So I'm going to get started. I'm going to stop showing my screen. And I think we can just jump right into questions, if that's okay with you. Do you have anything you kind of want to say before we get started? I don't know if you prepared anything. Okay.
Really not happy to take any questions, though.
Awesome. Oh, and I always forget to mention this as well, but if anyone has any questions that's on the line right now, they can jump into the chat and you can type them in right over there, and then I can do those live, really. Okay, so with that, I'm going to get started. So what I do when I do these is I put all these questions into like little categories, domains. So I'm going to start with some like epidemiology and really basic stuff. So first, do we know the incidence and the prevalence of Chiari malformation? So for anyone who doesn't know what those words mean, incidence is how likely, I guess, we are to see Chiari malformation show up. And then prevalence is how many people right now have Chiari malformation. So what are those numbers, and have they changed at all over the past X number of years?
Yeah, so that's a really good question. It's a deceptively simple question that, I mean, you could talk for hours trying to answer that question. I think we know a lot about it. We really do. But the answer has a lot to do with how you interpret the specifics of the question. So 30 years ago, there was a paper that came out based on an MRI study where they looked at a few thousand MRIs at an institution, mostly with adults. And they came up with the idea that Chiari malformation was like a 1 in 1,000 thing, and on MRI. And we all knew at the time that so that would be the MRI prevalence. We all knew at the time that the incidence of Chiari was much lower than 1 in 1,000. We don't have 1 in 1,000 Americans carrying a diagnosis of Chiari malformation. But on MRI studies, it appeared that that was approximately what the incidence or the prevalence was. Actually, there's been a lot more data over the last decade, though, which has sort of refuted some of that. I no longer believe that Chiari has a prevalence of 1 in 1,000. I think it's much more common than that when you're talking about imaging prevalence. You know, in our studies, when we primarily look at children, you can look at data sets with 50, 60, 70,000 MRIs now, you can find that in certain age groups that are most at risk for the imaging finding of Chiari, the prevalence is as high as 3% in the second and third decades of life. It's much lower in middle-aged to older adults. So middle-aged and older adults can certainly have Chiari, there's no question about that, but it's much less common. So actually the initial data, the 1 in 1,000 number, is correct if you're talking about really old adults, and that's primarily who they were studying. If you study the whole population, taking into account all age groups, it's probably more like 1 in 100. And if you study kids, in particular, kids in the second decade of life or young adults in the third decade of life, then it's even more common than that. So that's based on our data. There's also a nice paper in the New England Journal a few years ago that looked at the incidence of incidental pickups on brain MRI scans done for any reason. And they were not primarily interested in Chiari malformation, but they just sort of mentioned parenthetically that they found Chiari malformation in about 1% of their studies. That correlates really well with what we've been finding in the Chiari world as well. So sorry, that became a long answer, but I think the really short answer is, in the human population, I believe the MRI finding is about 1%. I believe it's less common in older people and more common in younger people. But taking everything together, it's 1%. The incidence, the rate of diagnosis of Chiari and having symptoms of Chiari is much less common than that. On an order, several orders of magnitude less common than that. So something like 1 in 1,000 of the people who are finding incidental pickup on MRI are actually having trouble on getting diagnosed with Chiari malformation. Now that is changing a little bit when you look at the United States diagnosis of Chiari right now. So we looked at what's called the Optum data set, which is a insurance database of 70 million people all around America. And if you look at how many people were diagnosed with Chiari in 2000 versus 2005 and 2010 and 2015 and so on, the rate of diagnosis has gone up. The annual rate of diagnosis has gone up by about 2.5 times over the last 20 years. So the incidence is definitely increasing. I don't, and we could debate why that is. I personally don't believe that symptoms are becoming more common. I think they're just getting diagnosed more frequently because people are more aware of it and they're looking for it more. So the rate of diagnosis is definitely going up. So therefore the incidence is going up.
That's interesting. I wasn't going to broach this, but now I guess I will ask. I'm going to debate why that's happening a little bit, like you just insinuated. So is this artifact from maybe radiologists reporting it on MRIs? So we actually had an incidence, not, it sounds like a very alarmist word. It was just something that happened in the office today, where we'd heard of someone who had had a mild trauma, but not to their head. And they had this MRI just to be careful, and they found a Chiari on there, but they've never had symptoms in their life and they didn't develop them. So is this something that may just be happening because it's being seen more? And then I will have a follow-up.
Well, I mean, yeah, well, that's exactly right, Caitlin. I think the diagnosis of Chiari, people who are walking around with a diagnosis of Chiari, is more common now for many reasons, but one of the reasons, again, is people are more aware of it. They're more likely to get diagnosed by their doctors. Also, though, the rate of MRI scanning, brain MRI scanning in this country has also gone up by like 2.5 times in the last 20 years. So that it would just stand to reason that we're finding more because we're scanning more brains, obviously.
Yeah.
So that's absolutely a factor as well. And we do more brain scans in this country than any other large first world country. Again, by an order of magnitude. The last data that I saw on that topic, we do more brain MRI scans, I think 3 times more brain MRI scans per person than Canada.
Oh my gosh, okay.
So, I mean, we do a lot of scans in this country, therefore we're gonna find a lot of things when we do our scans. But the rate of surgery is going up too, as well as the diagnosis of Chiari. And that would imply that it is also an increase in the number of detected symptomatic cases. I would like to think that most of the increase in Chiari surgery isn't on completely asymptomatic people.
Right. So this came up in the chat, and it was actually a question that we had prior to getting on the phone. And since we're talking about this, I guess we can address the elephant in the room. What is the 5 millimeter rule? Where did it come from? And what are your thoughts about it?
Yeah, well, I don't like the 5 millimeter rule. It's a gross oversimplification of a relatively complicated pathoanatomical concept. But the more we try to remove it and replace it with something else, we're left with the fact that it's very difficult to replace because nobody has come up with a usable replacement that we can all talk to each other about. So the beauty of the 5 millimeter rule is I can call you in New York and say I just saw somebody with 8 millimeters of tonsils below their foramen magnum, and you kind of have a picture of what that looks like. So it's really easy to measure, it's easy to communicate, and it does set some sort of a minimum standard for how we're diagnosing Chiari. So all of the numbers I just gave you, like the incidence and prevalence and everything, that all has to do with what we are calling Chiari in this country, which is the 5 millimeter rule. That's where all those numbers come from. There are a number of huge problems with the 5 millimeter rule. So it came out of a paper in 1984. Barkovich at San Francisco was the first author. He's a radiologist. And this is the dawn of the MRI era. So the first MRI scans were done in the late 70s, and then they became a little more popular in the early 80s. They still weren't commonly being done then, but they were at least getting done sometimes. So at that time, physicians started to see Chiari on MRI. And before that, they thought it was this incredibly rare thing that they would probably never see in their entire careers. Like, it was in the pathology books, but there was no warning to any of these radiologists that now that we're doing MRI scans, we're going to start seeing a lot of Chiari. So Barkovich was, I think, very well-meaning. He decided to try to set a standard for Chiari, because before that there was literally no standard. You would just call it Chiari if the tonsil seemed low to you in some kind of subjective sense. So he did something very simple. He took 25 Chiari patients from San Francisco, and he measured all of their tonsils. And then he took 200 people who he pre-selected as being normal, that is, or not having Chiari. And then he just compared the groups. And he asked the simple question like, what if I set the number at 10 millimeters? What would happen? Would I diagnose all the Chiaris or not? Or would I diagnose some normal people with Chiari? Okay, well, what if I set the number at 8 millimeters or 5 millimeters or 3 millimeters or 0? And using a series of sort of trial cut points, he came up with the notion that at 5 millimeters, all of the Chiari patients would fall into the Chiari group, and none of the normal people would have a Chiari. So he thought this was a really clean cut point and basically published on that. You introduced the concept of prevalence and incidence earlier. So another sort of useful public health term is positive predictive value, negative predictive value, and then specificity of terms versus sensitivity. So Barkovich claimed that with 5 millimeters, he was 100% sensitive and specific. But that's nonsense. He made it, he did the best he could in 1984. It was a really nice paper in 1984. But it is absolutely not 100% sensitive or specific. And why would he say it was when it wasn't? Well, because he was studying 25 patients. So it was true in that tiny little group that he was studying. But now we can study, 20,000 patients, and we know a lot more in 2020 than he did in 1984. So what have we learned, in the extra few decades that we've had to study the problem? Well, we've learned that a lot of asymptomatic people have 5 millimeters of tonsils below their foramen magnum. Barkovich said that was not possible. It's absolutely not true. Thousands and thousands of Americans are walking around with tonsils below their foramen magnum and have no symptoms. So it fails on that point. It fails also on the point of the idea that there's nothing that says that 4 millimeter of tonsils is normal and 5 millimeters is terribly diseased. And therefore, if you have a tight foramen magnum and limited CSF flow and classic Chiari symptoms, that you somehow don't have a Chiari malformation just because we can't measure you at 5 millimeters. Well, that's nonsense too. Obviously, you have a Chiari malformation, you just don't have tonsils that low. If we can see that you're pathophysiologically the same, like you have impacted tonsils, everything is squished back there, that's a Chiari. So then Jerry Oakes recognized that a couple of decades ago and came up with the concept of Chiari 0, where he said that, again, pathophysiologically, same thing. Everything's crowded back there. You got classic Chiari symptoms. You have a cervical syrinx, a big cervical syrinx, and that's a Chiari malformation. But because we don't have 5 millimeters, we're going to call it a Chiari 0. So I think that was a useful concept. So the 5 millimeter rule fails at both ends of the spectrum. It fails in labeling a bunch of people who feel perfectly healthy and normal as having a brain malformation. And it fails on the other end of the spectrum as telling people who have real symptoms of Chiari malformation that they actually don't have a Chiari malformation. So there are huge problems with it. Lots of groups have tried to replace it, and nobody has done it successfully, in my estimation. We've done it. We've tried to come up with. I mean, we studied 100 different ways of measuring the posterior fossa, the back part of the skull, the brain, the space around the brain, CSF flow, and we made we got excited at first because we found a few things that seemed to be important, like posterior fossa volume and clival length. And we thought, oh my gosh, this is the holy grail of Chiari. Now we can identify and predict who has symptoms and who doesn't have symptoms. And then we took that information and we applied it to a new group of people, not the group that we studied in the first place, but just a completely new group of 100 people. And we said, does this simple formula predict who's going to have symptoms or not? And the answer is no. It was completely useless. And other groups have done the exact same thing with similar results. There have been a few papers written where people have done the first part of that experiment without the second validation part of the experiment. And they've like, oh, we solved it. Now we know that there's like 3 other anatomical features you can study, and that's going to predict who has symptomatic Chiari. So now we have a replacement for 5 millimeter. And I wish those papers were not published because they're just confusing. Again, if you take that information and look at a validation group, it never has worked so far. Maybe somebody will find the answer someday. There's a lot of people still trying, but nobody's found it to their satisfaction yet. For me, I do use the 5 millimeter rule. I measure the tonsils. It's a simple starting point, but you can't be completely dogmatic about it. You have to take other things into account, such as how crowded does it look. That's very subjective, but it's an important subjective measure for me. Obviously syrinx is really important as well when we find that. People, again, I've sort of replaced it in my mind, but I can't communicate that to other people very well.
Yeah. There was an interesting question that someone had asked, the first question that someone asked, and it kind of fits well here. Have you seen that maybe MRI underestimates how big that herniation or how much pressure is put in that back space of the brain once you get in there and you cut open the dura and you kind of have a look around? Or is it pretty well correlated?
I mean, to be honest with you, I feel like it normally, when we open the dura, we normally find what we expect to see, to be honest with you, Caitlin. You're frozen on my screen, by the way. I hope I'm not frozen on your screen. Can you hear me?
Yes.
Okay, good. I think Caitlin is having trouble though, but I'm glad you can hear me. So yeah, I mean, in general, I have to say when we look at an MRI scan and then we go and look at the patient's anatomy in the operating room, it is normally about what we expected. It's probably not an exciting answer, but that's the truth.
Well, I'm going to be totally honest. I missed all of it because my computer froze, but.
Yeah. I was worried about that. But Dorothy, you could hear me, is that right?
That's correct.
Okay, good.
Okay, good. Cool. Then we can move on. There is a question, there are a couple of questions that are coming up sort of still related to this, so we'll stay with it. There's a mention that Millerat's study of 360 patients showed no correlation between tonsillar descent and severity of symptoms, which we kind of talked about. But
I kind of disagree with that a little bit. There is definitely a correlation between tonsil position and symptoms. It's just not a clean correlation. Like there's no cut point where you can say, well, nobody ever has symptoms without this much herniation, or you can't ever say, well, everybody has symptoms with this much herniation. There are no clean cut points. Having said that, that doesn't mean there's no correlation. There is a correlation. Somebody with 25 millimeters tonsil position below the foramen magnum is absolutely more likely to have symptoms than somebody who's at 15. And that person is in turn absolutely more likely to have symptoms than somebody who's at 5. So that's a good correlation. It's just not a correlation with perfect cut points. So I think that is not controversial. I mean, I think most people agree with that.
Yeah, I mean, at that point, you're arguing kind of the core of what epidemiology kind of doesn't always get right, is correlation versus causality. And I mean,
yeah, I mean, right. And obviously it's because it's not like the tonsils being low is what's creating the pathophysiological problem that is symptomatic Chiari. I mean, obviously it's not the lowness of the tonsils, it's the crowding. And I think we all kind of get that, but we just can't measure that very well. So we're using a secondary measure that's easy to measure.
well, to that.
But people with very low tonsils are much more likely to have crowded posterior fossas that are symptomatic.
Right. But to that point, there was recent studies out of Wisconsin and Children's National. This is the question that came up, that PCMR axial flow. These are studies of about 100 patients. They all exhibited abnormalities, and the types and degree of that abnormality seem to correlate with those severity of symptoms. Is that maybe something that is like clinically useful, or?
It hasn't been, at least for us. You know, obviously it is a nice research technique, and everybody is, for probably going on 30 years now, everybody has been working with MR flow studies to try to understand how we can use them clinically. And when they first came out, everyone was really excited about it, and everyone thought, oh, we've solved the problem because now we can just send people for this flow study, and people with impaired flow should get surgery. Well, again, that's very problematic, because lots of healthy, well-appearing, well-feeling people have impaired flow when we get flow studies on MRI. There is definitely a correlation, a little bit like we were talking about with the tonsils. Everybody agrees there's a correlation, and the more impaired your flow is, the more likely you are to have symptoms. The problem is, the lower your tonsils are, that's true as well. And then also we can just kind of look at you and talk to you and kind of get a sense for what your symptoms are. So with us, and we studied this at our place, and others I think have done very similar work, there is no question that flow measurements correlate with symptoms, but it's not perfect. And the real question that's important clinically is not, is there a correlation? The question is there a clinically useful correlation that will add something to our decision making? And at least for us, what we found is, if we know what the patient's symptom status is, and if we've looked at the MRI scan and we know what the morphology is, like how low are the tonsils, if they pointed, and so on, then having the CSF flow data actually never really changes our opinion about whether to operate on that person. In no case that I can remember in a couple of decades has that changed my mind. You already kind of know what the recommendation should be based on the patient's symptomatic status and what the MRI is. So 20 years ago, we got flow studies on everybody. In the last 5 years or so, I don't really care what the flow studies are anymore, and I mostly don't order them. The radiologists will frequently add them to our MRIs for Chiari anyway, because they're interested in it, but I don't order them routinely anymore. I don't find that they're helpful. I was on a panel a little bit like this one a few years ago with a number of people from CSF. And I thought it was really interesting. There were 5 or 6 people on the panel, and this question came up. And the question was, you know, nobody mentioned CSF flow in all of this talk about Chiari. How come that is? And do you still get CSF flow? And not a single person on the panel did, which, again, that was my feeling. I didn't realize that was what everybody else had moved to as well. So I think that's on the wane right now. Perhaps that will change if we can get better information about it, but that's been the case so far. Caitlin, I think I've lost the connection with you. Dorothy, can you still hear me?
I can. So
Okay.
I'm going to enlist, because I'm on my phone, but we're here in the office together. So can we go through some of these questions? So, all right. You want to take it, Mayor? Or you want me to? Okay. Let's see. This is a very good question. How often do neurosurgeons agree on the measurement based on the same MRI?
Yeah. Well, Dorothy, we looked at that at CSF a little bit, right? Brandon Rock was studying that, and there is definitely a disagreement. Um, I would say just subjectively, when we're giving second opinions and so on, my measurement and assessment of the MRI is usually very similar to other surgeons that the patient may have seen in the past. So it's quite unusual for me to make a measurement that's like radically different than what another surgeon would do. It does happen sometimes, but it's quite unusual. So I think yes, there are differences. Like it's not unusual at all for somebody to measure like a 7 when it's a 9, or a 5 and then it's a 7. Those are just measurement errors that are not very important. Yeah, I think it's quite unusual to see cases where I'm measuring 10 and somebody else thinks it's 0 or 20 or something like that. That just means they did it wrong, basically. But if somebody knows what they're doing, in general, you're going to be accurate within a few millimeters, I think. And you're going to see inter-observer reliability in that range.
Well, I agree with that. And I do know that there was a paper done by Oliver Wieben a few years ago where he was talking about MRI and the inaccuracy of that, depending on how it's done. So, and when you're talking about measurements, how important is it to go to a good MRI place, or what is a good MRI place to go, and what kind of study should be done?
Yeah, so, as I said, we have a Chiari protocol, which is basically a standard brain MRI, T1, T2, no contrast. We don't give contrast for Chiari. I don't think it's necessary. A lot of patients will get it anyway, but we don't ask for it. I think it's important to see at least the cervical spine. Most of our patients have complete spine imaging, but the cervical spine is what I'm basing most of my decisions on in terms of the decision for or against surgery. And again, the flow studies are usually done for us, but I don't ask for them anymore. Yeah, what's a good MRI? I think it should include the brain and cervical spine. At least it's nice to get more if you can. I like to not just see the posterior fossa. I like to see the whole brain, because you want to make sure that there's not something weird going on, that you're not diagnosing. Like you want to make sure you're getting the cases of secondary Chiari from, say, CSF leak or from hydrocephalus or a mass lesion and so on. So you need to rule that out. And in order to do that, you really need the full brain MRI. You don't want to just get a posterior fossa study or just make a diagnosis of a Chiari on a cervical spine study. You can do it. You can diagnose Chiari on a cervical spine, but I would never want to bring somebody to the operating room on the basis of just that study alone, because you might be missing a serious comorbidity that you'd only pick up on the brain scan. Same thing with the spine. I want to know if there's a cervical syrinx. And if it's just a brain scan, then you might miss that. So I would always, if I don't have those two components, I think that's critical and essential. I would send the patient back to get a complete study for that. Different MRI places have different qualities, of course. In general, frankly, Chiari is not that difficult to diagnose on an MRI. Like there are some neurosurgical diseases that if you don't have a really high quality study, you're just going to miss it. Chiari is not like that. I mean, almost any MRI place should be able to diagnose a Chiari if it's there, in my opinion. It's really hard to miss a Chiari if it's anatomically present on any quality of MRI. The open magnets are definitely lower quality than the closed magnets. A lot of people like the open magnets if they have claustrophobia, which is understandable. You will get a lower quality study, it's just a fact. For something like Chiari malformation, which is, again, hard to miss if it's there, it doesn't bother me that much if somebody wants to go on an open magnet, but they should know that they're going to get a lower quality study with the open magnet.
I am back, sorry.
Yeah.
Just when you were talking about that, someone had a question, why not the full spine? So is that something that, in what situation would you recommend that?
Yeah, I tend to make my surgical decisions based on whether or not there's a cervical syrinx. And that's just based on our data when we looked at Syringomyelia with Chiari malformation. The really strong cause and effect correlation that we were able to draw statistically were the large cervical syrinxes. So if someone has a small thoracic syrinx, I personally do not view that as a reason to operate. I might operate on that person for another reason. Perhaps they have Chiari headaches or they have other compelling symptoms that would cause me to want to operate on them. But if the person is not a surgical candidate because say they're asymptomatic, then having a small thoracic syrinx does not, for me in my practice, cause me to want to operate on that person. There's just frankly not a statistically proven strong cause and effect relationship between small thoracic syrinxes and Chiari. There's a really good, well-established statistical relationship between big cervical syrinxes and Chiari. There was a paper published about 20 years ago now pointing out that if you don't get complete spine imaging, you're going to miss some syrinxes. And that's true. There's no question about it. The question that I have, though, is do I actually make a different decision for that patient if I know about the small thoracic syrinx? And for me, the answer has become, based on our cause and effect conclusions, the data that we have, no. So I'll look at it if it's there, but if they don't have it, I don't send them back for it.
Okay. So what happens in the case of, say there's a lumbar syrinx and someone has a Chiari decompression and it just goes away after surgery? Is there any kind of reason that would happen? What's the rationale?
No, I mean, it's nice if that happens, but again, I don't think there's any statistical basis for making a decision on that basis.
Okay.
So, lumbar syrinx. So just to follow up on that, lumbar syrinxes are much more likely to be associated with tethered cord, either that or just what we call a terminal syrinx, which is just kind of a benign finding that people have. They tend to be asymptomatic. But if somebody has a lumbar syrinx, I'd be very interested in studying them for a tethered cord, not so much for Chiari. In general, that's true for Syringomyelia pathophysiology. If you just look at syrinxes anywhere in the cord, and Rick Batzdorf has always been a big advocate of this, the so-called idiopathic syrinxes that we don't know why people have it. Often you can find a CSF flow obstruction somewhere just above where the syrinx starts, like an arachnoid cyst or arachnoid banding or something like that. And that's true for Chiari as well. In general, the ones that we feel really confident that we know that Chiari is causing the syrinx tend to be pretty close to the Chiari.
Okay. So cerebellar position is one measurement. Are there any other measurements that you would make to kind of correlate with some clinical symptoms?
Well, we've tried very hard to do that with a lot of studies, and right now the answer is we can't validate anything else that matters. And other groups that said they've come up with it, again, you can't validate what they've done in a secondary group either. So I'd love to be able to answer that affirmatively, but there's no evidentiary basis for doing that right now. Now, if you're going to operate, though, there are some other things that we know matter with respect to what kind of operation you're going to do. So you look at the dens and whether it's retroflexed. You look at the clival angle to see if there's any evidence for any kind of skull collapse or anything like that. So you want to look at lots of features of the MRI if you're operating, but not necessarily with the decision about whether you should operate.
Okay. So would you say that the decision to make that surgical intervention is really based on symptoms, or how do you really do that?
It's symptoms and the presence or absence of a cervical syrinx for me. So if you have a large cervical syrinx, in general, we advocate for surgery, even prophylactic surgery in an asymptomatic person. If you have no syrinx, then it's all about your symptoms, and it's a quality of life operation, essentially. We talk about whether your symptoms correlate with the Chiari, whether it's most commonly headache. So we go through the checklist and features of a headache and try to sort out how likely is it that your headache is from the Chiari. And it's virtually never 100%, and it's never zero. It's always somewhere in between. But we're much more likely to offer surgery if we think that it's very likely to be from the Chiari based on the features. And then the other very, very important part of that is, okay, let's say we say it's from the Chiari, how much is it affecting that person's quality of life? So I might see a patient that has an incredible headache problem, but their headaches last for 4 hours and is associated with vomiting, and they see, flashes of lights in front of their eyes, and well, they have migraines. So we're not going to offer surgery, at least not for that symptom, because we're not going to fix a migraine headache with Chiari surgery. The converse of that situation is we have patients sometimes that will see us and they have a Chiari, and we'll go through their headache features, and they have a headache in the back of their head, and every time they cough and sneeze, it comes on, and it lasts a few minutes and it goes away, and it's 100% a Chiari headache. We feel very confident we can fix that with surgery, and they'll say, oh yeah, but I don't want brain surgery. It doesn't really bother me at all. I mean, I have a great life and I get this thing once a month, so who cares? So for that patient, surgery is not necessarily a good idea either, because it's a quality of life operation. And if your quality of life is excellent and you're not bothered with symptoms, then why would you do it? So really, for the headache surgery, if we're doing a Chiari surgery for a headache, they need to kind of check both boxes for me. Like, is it likely to be from the Chiari? And if so, does it bother them enough to justify having brain surgery?
Right. Yeah, it's a big decision.
Yeah.
To that end, so quality of life is really the question for, I guess, kind of older children and maybe into adults. But what about in infants or toddlers or even those really younger children? So how do you know, what a specific question is aspiration in an infant or a toddler kind of an indication that surgery is needed? How do you know in those little babies?
Yeah, it can be really hard to sort out. It's always hard to sort out. The classic description that we'll get from parents of very young children is that the kids will be playing and will get active, and then we'll just, for reasons they can't discern, just stop playing and sit quietly and sometimes grab the back of their head. So even when the children are not communicative, in a verbal sense, they're able to communicate their symptoms by these kind of nonverbal cues sometimes. So in that situation, if the parents are giving me a description that's that clear, and there's a convincing MRI picture, then we can talk about surgery. More commonly, it's frankly more difficult than that, because you have an MRI that shows a Chiari, and you have symptoms that you're not really sure are from the Chiari or not. Maybe there's a headache because he was fussy a few times last month, but you're not really sure. And in those situations, often we'll drag our feet a little bit, and we'll stay in touch with the families and say, you know what, why don't you pay attention to what the symptoms are, and we'll talk again. And usually it'll become clear eventually, one way or the other. Like either the fussiness was some unrelated thing and got better, and the parents are happy that they didn't have surgery, or the symptoms will continue and it will just become more clear over time that it's from the Chiari, then we'll operate. So we will do a few operations on very young infants every year, but not many. It's much less common than older children. The most common time to have Chiari surgery in pediatric practices is the second decade of life. It's the teenagers for the most part. We'll do some infants, but it's unusual. And obviously the most in adult practices, it's the young adults. And those are the 2 decades of life. The 20s and the 30s are the teens and the 20s are the 2 decades of life when your tonsils are at their lowest point anatomically. So they're a little higher, and then they go down for the second and third decades, and then they go gradually up and up and up and up throughout life. So I do believe that probably correlates with the ages when we're just seeing all of our symptomatic patients as well. It just makes anatomic sense. Did that answer your question?
Yes, there's a little bit of a follow-up, and it's kind of asking, I guess, what are you looking for in those infants and young kids? So is it gross motor delays, aspiration, speech delays, something specific?
Yeah, so I'm mostly trying to get a sense for if they're having the Chiari headaches. Now, if they have sleep apnea and I send them for a sleep study, then that's really helpful as well, because that's objective evidence. Where now I have a piece of paper or report from our sleep study person that says there's actual central sleep apnea. Now that really can help us with a surgical decision, because now we have the MRI, which is objective, and we have an objective sleep study. So if we're trying to discern if the headaches are from the Chiari or not, and we can't decide if surgery is a good idea, that's really helpful. So I don't send everybody for a sleep study, but if there's any question that there's difficulties like that, then I do. So that's what I look for. Again, though, I'm not very aggressive about pushing parents of infants to have surgery. If we're not sure, we just wait. Um, Mike Scott, 20 years ago, wrote a nice paper showing that, and he's an excellent surgeon, but even in his hands, he was showing that sometimes when you do Chiari surgery on the really young kids, like less than 5 years old, it's definitely more likely that they're going to get in more trouble later in life and have to have repeat surgery. So, that's not to say you shouldn't do it early in life. We do, but it's just, one more reason to just be a little bit cautious, obviously.
Yeah. I'm jumping off that. So
Yeah, the question about the motor delay is a real slippery slope. But I do believe most pediatric neurosurgeons would not offer Chiari surgery for motor delay. There are some that would. But that would be incredibly controversial. There's just simply no evidence that it helps. The trouble is lots of kids get better after Chiari surgery. The problem with proving that that was actually helpful is that most developmental delay gets better as kids grow up anyway. So I like to think about it like a pill that I was marketing. If I have a new pill and I wanted to sell it to you to help your kids motor delay, would the government let me sell it? Would it get through the FDA on our currently available knowledge? And the answer would be obviously not. We could never sell that pill. Now, surgery is much less well regulated than drugs in this country. So I would be allowed to sell you the surgery. I couldn't sell you a pill because there's no evidence that it helps. I could sell you an operation even though there's no evidence that it helps. But I try not to do that. So very, very controversial. Some people will do it. I don't. I will do it if I can find some other reason to operate that is more proven.
Yeah. What are some of the symptoms of surgery? So if someone has not so terrible symptoms in a child, maybe elementary age, the symptoms aren't bad, they seem to come and go.
Yeah.
What's the risks of going through a surgery? Or is it possible that it's going to get better on its own? So as you say, the tonsils can come back up. What's going to go on there?
Yeah, it's definitely possible to get better on its own. It's also possible to get worse, unfortunately. So we did a so-called natural history study, which is looking at kids with either no symptoms or symptoms that you described, kind of minimal symptoms that are coming and going, where parents thought, well, I'm not in a hurry. Let's just see how this goes. And when you do a study like that, we at that time had 150 kids that we followed. The Miami group had a similar study. They looked at about 100. There was a study from Italy that was relatively similar. They had 30 or 40 people. So a number of groups have done this now, and everybody's finding the same thing, which is that most of the kids that are asymptomatic or minimally symptomatic will stay about the same over many years. But some of the kids, and in our group it was about 10%, got worse and came to surgery. So they were okay-ish when we saw them, and we said, let's just kind of see how it goes for a while. 10% of that group ended up getting operated by us over time. I don't necessarily view that as a sign that like the wrong decision was made in 10% initially. I view it as a point that, well, in 10% of the cases, it just wasn't really obvious at first, and it became more obvious with time. Now, an approximately equal percentage of the group actually got better. So they had minimal symptoms and the symptoms went away. Interestingly, you can see the same exact pattern on MRI when you follow kids over time and you say, well, okay, my tonsils are 10 millimeters below the foramen magnum in 2020. What is my MRI scan going to look like in 2025? And it's the exact same story. Most of the time, your tonsils will be the same, but a certain percentage, a small percentage of people will definitely get better. We've even seen Chiaris just go away spontaneously. We've published on that. There are a number of examples of that. It's not common, but it absolutely happens. We've seen a Chiari go away and a Syrinx go away in a patient, which I thought was remarkable. They somehow like just slipped through our clinic without getting surgery. I still don't really understand how that happens, because ordinarily I would recommend surgery for that person, but there they were. They had a Chiari, they had a Syrinx, and they didn't have surgery. And then we saw them back, and it's like, is this even the right person? Because they don't have a Chiari or a Syrinx anymore. So that happens. Other people have seen that too. But the bad news is that is balanced with another small group of people who we saw and thought, oh, this is really mild looking and you don't have any symptoms. And you see it back, and the Chiari is much worse. And now they have a Syrinx and they didn't have one before, and now they're getting surgery. So, it's very difficult if you're a parent or an individual and you want to know what's going to happen with your child over the next 5 years. It's very difficult to counsel them in any meaningful way, because the short answer is, well, anything can happen. You can get better, you can get worse. That's not very helpful to know. But the vast majority of people stay about the same.
Okay. So if a patient maybe has the normal, quote unquote, brain MRI, they don't have any into the cervical cord, there's nothing going on in there. What are the other disorders that can mimic those symptoms that maybe should be checked, especially if the symptoms are pretty bad, before you go through with Chiari surgery, I guess?
Yeah, well, so in your scenario, Caitlin, they don't have a Chiari on their MRI, is that right, or they do?
They don't. So they have all the symptoms, and it's bad enough that something should be done, but there's nothing visible.
Right. Well, without a visible Chiari, we wouldn't do a Chiari surgery. So the sort of the whole concept of like, what should I look for before Chiari surgery? Well, I wouldn't do the Chiari surgery if there was no Chiari. Other things that you have to look for, kind of depends exactly what the symptoms are, frankly. I don't think it would be fair to just provide a laundry list of all sorts of neurological conditions, because they all have individual presentations and symptoms. Things that can often be confused with Chiari, though, are obviously tumors. Can cause headaches. They sometimes can be relatively hard to diagnose if they're diffuse tumors. Cerebellitis can do a lot of those sorts of things. CSF leaks can mimic Chiari on MRI and can cause incredibly awful headache problems, and can be very, very hard to diagnose. Lots and lots of people in America, even today, with CSF leaks can go through multiple doctors before they're properly diagnosed. And that can be a terribly, terribly devastating problem to have, with incredibly bad headaches. So that would be something I guess I would keep in mind as well. But honestly, it just depends on the symptoms. It's hard to know unless you knew what the symptoms are. And then, the other fact of the matter, though, is that just a lot of people with headaches that do not have an MRI abnormality probably do not have a neurosurgical cause of their headaches. I mean, most headaches do not have a neurosurgical cause. And it doesn't mean that they're not a terrible, awful problem. It just means that surgery will not help. And at that point, they need to work intensively with a neurologist, headache expert to try to get their symptoms better. And the good news is most of the time that's effective. But it is something that I think people struggle with, because sometimes the severity of the symptoms would indicate that there must be something that needs surgery, and that's not necessarily true.
Yeah. To the point about headaches, what I know we kind of talked about this, but what actually is a Chiari headache? And at the back of your head, you can get a bunch of different types of headaches. So how do you know how to differentiate that?
Yeah, so the American Headache Institute actually has a headache classification, which is really helpful. They have like a migraine headache classification and a tension headache classification, and actually they have a Chiari headache definition now, which a really good expert panel of neurologists came up with. I was slightly disappointed when I read it. It is helpful, but unfortunately, like, their main way of diagnosing Chiari headache is that they call it a headache that gets better after Chiari surgery, which is true. And it is a really neat definition, but it's not helpful if you're a patient trying to decide if you should have surgery for your headache, because you're not going to just do the experiment and find out if it gets better and to find out if you have the Chiari headache or not. But so that was one part of their definition. The rest of their definition was more helpful, and I do agree with it. And so they were pointing out headaches that are in the back of the head, that are generally short lasting, and that are brought on by coughing, sneezing, straining, exertion, are very likely, especially in combination, are very likely to be Chiari headaches. Now, Chiari headaches don't have to be that way. Obviously, everybody knows and have seen instances of headache that are associated with the Chiari and that do not neatly fit that description. But if we're making a surgical decision, it's just a statistical fact that we're much more likely to help people recover from their headaches if they have headaches that fit that description. So if somebody comes into the clinic and they says they have a headache in the back of their head and it lasts for 5 minutes every time they lift weights and then they get better after a few minutes, again, there's an extremely high likelihood that we're going to fix that. And if somebody comes in and they say they have headaches all the time in the front of their head, there's, just statistics, and it's not just our clinic. Every study has shown that that's a person who's going to have a much lower likelihood of getting better from their headaches, but not zero. It's never zero. So sometimes people will get better from their headaches, even with that sort of a description. And I've had patients that I've operated on because they have a great big cervical spine syrinx, and I've recommended an operation on that basis, and then they'll give me a headache description, which is one side of my head up front. It lasts all day. It's awful. And I said, we should fix your Chiari because of the syrinx. By the way, I'm not really optimistic about your headache. Let's not do this operation for your headache because I don't know if that's going to get better. And then it gets better. So that's great. I love it, but it just goes to show that I certainly can't predict with any degree of certainty in many cases who's going to get better and who's not. But we can make general guesses on the basis of the headache classification that I mentioned to you. Eventually, a headache description goes so far off of what we are looking for with respect to a Chiari description that it's hard to justify taking a chance on surgery. If I honestly think you have a 10% chance of getting better, then I don't think you should expose yourself to the risk of brain surgery. That shouldn't be good enough. You should have brain surgery if there's at least, I think, a better than 50-50 chance that your headaches are going to get better. I think just as a baseline, that's where I personally would set my baseline. Other people might feel differently. This is not right or wrong. This is not exactly science, but we got to call it somewhere. And for me, I think I will sometimes offer a headache operation to somebody who I think is going to have a 50-50 chance of getting headache relief, but I'll want to make sure to counsel that patient very carefully and tell them that this may or may not work, and we're going to have to decide if you think it's worth going through and exposing yourself to the risks. So having said that, that was the other part of your question. What are the risks? The most commonly seen risk of Chiari surgery in America right now is getting CSF leaks and pseudomeningoceles. Unfortunately, very common. I try to be really, really, really careful when we close the dura when we do Chiari surgery. So in general, I don't get any CSF leaks in my practice. But in America today, that's the most common thing is you either get spinal fluid leaking out your neck after surgery, or you get a great big bulge in the back of your head from a pseudomeningocele. And those are incredibly problematic. When people get those, it can cause chronic pain. It can just be absolutely miserable. In my opinion, when people get those after surgery, it really should be fixed right away, and not by putting a shunt in. It should be fixed by going back to the Chiari repair and doing it properly with a really good closure of the dura so that you don't get a leak, so that you don't get a chronic neck pain problem, which is what those can turn into. So CSF leak is the most common thing that you worry about. You can get an infection just like with any other operation. You can get an infection. Pretty uncommon, fortunately, with brain surgery because the scalp is so well perfused with a great blood supply. But it definitely can and does happen sometimes. Really severe problems like brain injury, strokes, that sort of thing should be incredibly rare. It can happen. I'm not going to name a name here, but one of the people in the field who I most admire, and I really believe he's an excellent technical surgeon, has lost a patient on the table. The patient actually died in Chiari surgery, and I do believe that this surgeon is an excellent technical surgeon, and that I would feel very safe having him operate on a loved one of mine. But he's lost a patient in Chiari surgery, so I share that story with some of my patients because I want them to understand that anything is possible when you sign up for an operation, and you don't expect something really terrible to happen. And that's a incredibly unlikely event. Obviously, it's the worst thing that's ever happened to in this person's career, but it's not impossible. Brain surgery can be serious. So I personally have never seen any permanent brain injuries or deaths or anything like that in the practice, but it's not impossible. There could be a first time for something serious like that.
Yeah. There's no such thing as no risk. So
That's right.
before we kind of talk more about surgeries, there was a question that came up similar to how Chiari, the idea is maybe you can outgrow it. Is the same true of tethered cord or tethered cord syndrome? Because on one of our recent things, we discussed how those things are different. But have you seen that?
Tethered cord syndrome is essentially having the symptoms of tethered cord, and tethered cord can be an imaging diagnosis, a little bit like Chiari. That's a whole other topic, obviously. It is sometimes very straightforward to diagnose tethered cord because you can see the bottom part of the spine is really, really low, and it's a no-brainer diagnosis on MRI. It can sometimes be more difficult if the spinal cord is not very low, maybe it's just subtly low, and for complicated statistical reasons that in that individual that might be actually worse than what you think it is, because not all of our cords are programmed to be at the same height. And if you were one of those people that was programmed to have a really high cord and now it's normal, like perhaps it's actually getting stretched. So having said all of that, there are at least subtle features of tethered cord and lots of normal individuals that are perfectly happy and healthy and walking around and just happen to get an MRI scan for some unrelated reason. So that's common. Tethered cord syndrome, on the other hand, is relatively rare. The most common symptoms of that are back pain, leg numbness, bowel and bladder changes, or leg weakness, or some combination thereof. The most common symptom of that list is back pain. When I'm operating on somebody for tethered cord, I generally feel more confident if I'm operating on symptoms. I feel more confident if there's some combination of those. If they just have one of those symptoms, it's possible. It's certainly possible. But you wonder a little bit about the diagnosis unless the MRI is very, very clear. There are some physical examination features, which I'm not going to get into, which will help you make that decision as well. By the way, can somebody outgrow it? That answer is not scientifically proven one way or the other. My opinion is people probably do not outgrow tethered cord symptoms if they are tethered cord symptoms. It's a little bit like Chiari. One of the problems with diagnosing tethered cord syndrome is that the symptoms like back pain is incredibly common in the population with or without tethered cord. So then it's a little bit like having a headache and a Chiari. You got to spend a lot of time trying to sort out, is this back pain coming from the tethered cord? If you have back pain and you may or may not have tethered cord on your MRI, and then your back pain just goes away and stays gone away forever, I don't think you probably, in my opinion, in that hypothetical scenario, you probably didn't outgrow your tethered cord symptoms. You probably just had back pain for another reason. Not everybody with tethered cord on their MRI has symptoms or even will ever get symptoms. We talked about the correlation between tonsil position and symptoms, like the lower your tonsils are, the more likely you are to have symptoms. It's the same is true for tethered cord. The lower your spine is, the more tethered it looks on MRI, the more likely it is that you are going to have tethered cord symptoms. We wrote up a series of those a few years ago, and at least in our estimation, if you have a spinal cord that was 3 segments too low, over half of those kids had symptoms. Whereas if you have a spinal cord that was within 1 segment of normal, then very, very few of those kids had symptoms. Mostly it was just an incidental pickup. So how low your spinal cord is does kind of predict that. We'll do a so-called prophylactic untethering operation with no symptoms when your spine is really, really low, just because we think it's very likely that you're going to have symptoms eventually. When your cord is a little bit higher, not that low, we won't do prophylactic operations. We'll just watch out for any symptoms if they arise.
Okay.
So yeah, I suppose, again, you asked a simple question, you're getting a complicated answer. I never say never, and I never say always. There's always exceptions to every rule. So could somebody outgrow their symptoms? Yeah, I guess, maybe, possibly, but I've never seen it. I think if you have real tethered cord symptoms, it's probably just going to keep getting worse. That would be the expected natural history there. But if you don't have any symptoms at all, you might never get them.
Right. Okay. So I'm going to talk more about surgery now that we're all the way in. How many decompressions do you do maybe in a year or in a month? And is that something that patients should be looking for in the surgeon that they see for their surgery? How well specialized do you think the surgery is, I guess?
I think the operation is, I think it's deceptively simple. What I mean by that is conceptually, it's relatively easy. I think almost every neurosurgeon in America thinks they know how to do this. It's not really technically demanding to do an average Chiari operation. But there's a big problem with that because we were talking about all of the complications that people get and the CSF leaks and pseudomeningoceles, and that can absolutely devastate patients. And that is something that surgeons really need to pay attention to. So I think every or most neurosurgeons in America feel like they can do this operation, but in my estimation, yeah, I do think it's something that you should ask about. How many have you done? What's your success rate? What's your rate of getting leaks? How would you handle it if you got a leak? Because you really want to avoid that complication. You want to avoid any complications. So I think probably just like any operation in general, I mean, I can't think of really anything that you shouldn't ask that question for. But yeah, you should ask your surgeon how many they've done, what their success rate has been, what their complication rate has been, and whether this is something that they consider themselves expert in. Because if it's done poorly, it can be devastating, and in some cases, it can affect many years of your life before you can actually get your life back on track. So, yeah, I think it matters a lot.
Is there a good number, or is that a loaded question?
I think I don't think I would set an extremely high minimum number. I probably I see a couple hundred Chiari patients a year probably and operate on about 50 of them a year. I'm pretty selective, as you've heard, in terms of who I'm recommending surgery for. At least I think I am. I think that if somebody does fewer than 10 a year, they're probably just not really a Chiari malformation person. They're just a neurosurgeon. I shouldn't say just a neurosurgeon, but they're a neurosurgeon who just does a lot of other things and happens to operate on the Chiaris that come in the door. I guess I'd be, and they might do a great job in some cases, but you should know that they're probably not very thoughtful about Chiaris as much as whether or not you get a good operation. I think I'd be equally concerned about whether they're helping you make the right decision. Are they recommending surgery when you need it, or are they not recommending surgery when you don't need it? And I think that's relatively good to know that you're seeing somebody that sees a lot of Chiari and is thoughtful about Chiari with respect to that as well. Now, even people who see a lot of Chiari, frankly, you'll see disagreements, and I think that's very frustrating for patients that see three people that all consider themselves experts in Chiari, and they got three different answers, and people wondering how could this possibly be. And unfortunately, that's just the state of the science right now, is that there is going to be some disagreement, especially if you're in kind of a gray area. But at the same time, I think at least seeing people that see a lot of Chiari is helpful. Yeah. So yeah, again, simple question with a complicated answer, but I think it is a simple operation to do. Like most people can do it, but that you don't necessarily want to just have the basic operation by somebody who's done it a few times. I think you're going to be in better hands going to somebody who does a lot.
Is there a way? How would patients? So say they go into the whatever hospital they're at, whether or not it's medical academic institution, how do they know whether that surgeon's qualified or how familiar they are with the surgery? Is there a way to do that?
Well, yeah, there's a lot of ways to do it. I mean, the simplest way is you should ask them. I think everybody should feel very comfortable with their surgeon. If you're afraid of asking them that question, then you don't have a good enough relationship with them to be your surgeon. I'm never offended by those questions, and if the surgeon's any good, they really shouldn't be. So ask them directly, like, how many Chiari surgeries do you do? Have you written papers on Chiari? Do you think about Chiari? Are you in CSF? These are kind of basic questions. And the other ways you can do a little bit of a background check is just go to their website. Do they talk about Chiari on their website, or do they talk about, doing a lot of disc surgery or brain tumor surgery or some other thing? I think it doesn't mean that they're not a Chiari expert if they don't mention Chiari, but you know, you might want to seek out somebody that's at least talking about Chiari. And then other really good things is, you know, look at their board certification status. So the American Board of Neurosurgery, abns.org, maintains a list of all board certified neurosurgeons in America. And your neurosurgeon should be board certified. So if you have an appointment with somebody, just look them up and see if they're on the list. And if they're not, and you want to keep your appointment, maybe ask them why they're not on the list.
Right.
But I think that's another very basic thing that you should do to check out. You know, depending on what state you live in, there's ways of retrieving malpractice history of physicians in some states. That's another thing that I think is reasonable to check out. The state of neurosurgery in America right now is there are some very good neurosurgeons that have a malpractice history, but you want to make sure that there's not too much of a malpractice history that's sort of, you know, in some cases the malpractice history kind of tells a story, and you want to make sure not to see somebody like that. So I think that would be my best general advice. Ask the surgeon directly the questions that are on your mind, but yeah, you can do a little bit of a background check too.
Yeah, nothing wrong with that.
CSF, right? Do you mind if I say that, Caitlin? I think your office gets a lot of these sorts of questions, right? I think as far as I know, you've told me that your policy is not necessarily to recommend individual people, but you'll at least provide this sort of kind of general advice, I think.
Yeah, we basically, you almost said it verbatim. So
yeah.
That's kind of what we tell everyone to do. If someone has had multiple decompressions, does that increase the risk of a CSF leak, or is it the same?
No, I think it's about the same. It does increase the risk of not getting better, though, unfortunately. So if I see somebody for a second opinion after a decompression where they have now persistent symptoms, you know, there are some cases where you can help those patients and relieve their symptoms, but the odds go down. So in general, for these sorts of second opinions, if you're going to offer a repeat decompression, I do want to see something anatomically that I can fix. So I'll offer it if I can look at their brain scan and say, you know, yeah, you still have a tight foramen magnum, we can fix that, or you have a pseudomeningocele, we can fix that. So in those instances, it's a good idea to have a repeat decompression, and I'll offer it. I do not generally offer repeat decompressions for patients I see in second opinion where I look at the scan and I think, wow, you know, you don't really have a Chiari anymore. It looks actually quite good. And all we can do is make it look that good, then you know, I'm probably not going to help you either, is just the bottom line. So I think that's the main thing for people to understand, that the odds of being helped, unfortunately, you know, just keep going down with repeated surgery. And it's, I think Napoleon is credited with this phrase, never reinforce failure. And if somebody has had a good operation and it's failed, that doesn't necessarily mean that they just need to go out and have another operation. It might mean that even a good operation will not help. And we know that there are some people who probably just can't be helped with surgery. And sometimes it's just important to recognize that. Now, I mean, the opposite is true too. There are also individuals that were not helped by their first operation and were absolutely cured by their second operation. But again, you need to have a plan for what's going to be different the second time around.
Right. Kind of to that, you hear about patients having these reoperation surgeries, and you hear these horror stories of some people having up to 20 surgeries in their lifetime. So doesn't the idea of having a really good surgical success rate and 20 surgeries in a lifetime seem kind of counterintuitive? Is there anyone that's tracking reops and studying that?
I think it's a huge red flag. You know, if it's another good thing to ask your surgeon, how many of his primary decompressions, a patient who's having their first Chiari operation, like what percentage of those patients are ending up getting reoperated on? They might not know, because many times the second operation goes to a different surgeon because the person's not satisfied with their outcome the first time. But it's a huge red flag if there's a track record of a lot of people having other surgeries after somebody operates on them. You know, as far as I know, my highest number of operations on a Chiari patient is 2. And I can't imagine that really should be any different. I'd be very concerned if anybody was operating on people over and over and over again for Chiari.
Yeah. So this is more technique, I guess. What's your take on, do you always open dura, and what about resection of tonsils?
Yeah, that's really a hot topic right now. I do. I always used to open the dura, and I used to always coagulate the tonsils up. That was my standard Chiari operation for many years. And then, as I'm sure most of the people on the call know, over the last decade or so, there's been a little bit of a push to do a so-called bone-only decompression. Some published evidence suggests that the bone-only surgery was an effective operation in many instances, and it certainly was much easier for the surgeon, and I think easier on patients. Patients left a little earlier and stuff like that. So on the basis of that published evidence, I started to do some bone-only operations. I want to say starting probably about 8 years ago and ending about 4 years ago. I call it my bone-only phase, where I gave it a try based on the literature. I thought maybe there's something to this, and I was extremely unsatisfied with my bone-only results. And it was true for my partner as well, who also does quite a few Chiari surgeries. So we went through our bone-only phase, basically feeling like we never, ever had to reoperate for failure. It was an incredibly rare event back when we were doing it with the opening the dura and coagulating the tonsils. And we were seeing a much larger number of primary failures with our bone-only operations. So we brought a number of them back. I think I brought 3 or 4 people back for duroplasties in my own personal series, which again was unprecedented in my prior practice with opening the dura. And so for the last 4, at least maybe 5 years, I don't do bone-only operations anymore. I never do them anymore. I personally don't believe they're effective, at least not for me in my hands. I think other good groups do the bone-only and like them, so I'm not going to try to speak for everybody. But for me, if you're coming to me for a Chiari decompression, I'm opening your dura and I'm coagulating your tonsils, because at least for me and my personal results, it's much better that way. I was in the Park Reeves study, which some of you may know was a study designed to essentially answer this question and show whether opening the dura was helpful or not. And I had to drop out of that study halfway through on the basis of my personal conviction that I couldn't, in good conscience, randomize patients anymore to either have their dura opened or not. I agreed to enter that study in my bone-only phase, thinking, well, we'll give it a try. And halfway through, I just thought, I can't do this anymore. I'm just going to have to open everybody's dura. And I think other people feel that way too, that were part of that study. I'm not allowed, I think, to share any of the results of that study, even though it's...
Okay.
Not yet, not yet.
Yeah.
Okay, so one more surgical question, and then I have kind of a long-term management question that is actually a repeat from an old lecture that you gave. But in a patient with progressive scoliosis and Chiari, so say they probably will need a surgery for both. Which one do you do first and why?
I'll definitely do the Chiari surgery first. I mean, so if they have a Chiari and a large cervical syrinx and scoliosis, I'll 100% recommend surgery for that patient, because there's really good scientific evidence that the Chiari is causing the syrinx and the syrinx is causing the scoliosis. I'll definitely do the Chiari first. If they fix the scoliosis first, especially if there's a long delay, there's a really significant risk of scoliosis worsening despite the instrumentation, because the primary driver of the problem hasn't been fixed. So you really need to do that. It's like an 18-wheeler rolling down the highway, and the Chiari malformation is the foot on the accelerator. And if you want to stop that truck, the first thing to do is take your foot off the accelerator. So yeah, you got to fix the Chiari first, in my opinion. So our orthopods here are pretty good about sending those patients to us first. Usually the syrinx gets better quickly. Usually on a scan that we get 3 months after surgery, the syrinx is gone, or at least much smaller. And in that case, then they proceed with the scoliosis operation. So it doesn't lead to a long delay in the scoliosis repair.
That's good. Okay. So you had answered this question. We looked it up. It was in 2016, so this was a long time ago. I thought it was more recent. But if surgery doesn't help with pain, what are the pain management options? like what actually works. And they had a follow-up asking about, can you speak to the potential dependency issues and what that means for longer term management of the same pain problem?
Yeah. So, really, I'm out of my depth on that question, Caitlin, because, I'm not a pain management expert. I'm fortunate to work in an institution that has a pain management expert that I will send my patients to. But, all of those issues are very important, obviously. Um, this isn't a very helpful answer, but I think it's the truth that I don't think there's a one size fits all approach here. I don't think it's possible to say, oh, everybody should try this drug because it's going to be great. If that was true, then everybody would just buy that drug and all of the other drugs would not be on the market anymore because we would have figured that out. But it's not that simple. What we have instead is a situation where some things work for some people but not others, and completely different things work for those other people and not the first things. So it's a real question of trial and error. I think for patients, the most important thing is to form a good ongoing relationship with somebody who has an interest in pain management and who's willing to try a bunch of things with you and not give up after the first or second thing didn't work. The patient shouldn't give up and the doctor shouldn't give up either. It needs to be a good ongoing relationship until you find something that will work. Addiction is a real problem. Again, I'm definitely not a pain management expert. I don't want to pretend that I am, but my little editorial on that is, in general, it's a bad idea to be on something long-term that's addictive because it doesn't, number one, you're addicted, and number two, it actually doesn't tend to make you feel better over the long term because eventually the effect will wear off, and at that point, you're just taking the drug for the drug's sake and not for any of the original pain relief that you got from the drug. So most, as far as again, I'm not an expert in this field, but I do believe most pain management experts for a chronic pain problem, especially in a younger person, would steer away from addictive drugs just for that reason.
Do you ever prescribe isn't the right word. I can't think right now. Refer to physical therapists for that kind of stuff?
So,
okay.
So I don't. Again, this is something that, fortunately, at least at my medical center, will refer to physical medicine and rehabilitation pain experts. They'll do the pain part and they'll do the physical therapy part. So absolutely, physical therapy can be a really important piece of the puzzle. I personally don't run that part of it, though. I suspect that's probably true at most big medical centers, at least.
Well, I think unless anyone has a late-breaking question, I'm going to extend this sentence a little bit, and I'm not seeing a question. Okay, so I think we're good then. I don't know if you have anything that you want to mention before we sign off. But
no, it was a pleasure. Thanks everybody for calling in and joining us today, and I hope that was helpful.
It really was. Thank you. Thank you so much,
Dr. Maher. Thank you.
Yeah, thanks very much to Caitlin and Mary and Dorothy for organizing.
Yeah, sorry for my technical glitch, by the way.
Yeah.
All right.
It's just the way of the world in 2020. It's every time.
What else? It's just
I'm glad it was you and not me. Sorry.
Thanks, everyone.
It's usually me.
Good night.
All right, good night.